Hi, I'm Blake Gillette. I'm an orthopedic surgeon at Canyon View Medical Group in Spanish Fork. ACL is a big topic in sports, ranging from the young adolescent athlete all the way up to the 60-year-old who is actually functionally very active but tears their ACL. So it's a huge topic, and there's a myriad in ways of fixing the ACL. Start with the younger athlete. Especially with as much sports as the kids are involved in these days, it's a huge topic. So kids that are still growing, so they actually have open growth plates, it's more tricky to do the ACL because you don't want to do anything that might cause disruption to the growth plate. So depending on the maturity level and how much growth they have remaining, generally we avoid any type of ACL reconstruction where you actually are fixing the graft with screws in tunnels because those screws can affect the growth plate. And so generally we use a suspensory mechanism such as like a button on the femur that holds the graft but doesn't have anything other than graft tissue going across the growth plates. In addition, we'll usually use, again, their hamstring, their own patient's own hamstring to end with the button. And the same thing on the tibia. We do something that is fixed outside of the growth plates so as not to affect growth. Now as we move up to the more mature athlete, it depends on the type of sports you do. So if you're a very high-level soccer player, for instance, you're going to be doing a lot of pivoting, a lot of twisting, or a high-level football player, you need to have the strongest graft possible, and usually you're trying to get back as fast as you possibly can. So in those cases, we'll generally use what's called the bone patellar bone autograft. So on the same side, the affected side, we'll take a plug of bone from the kneecap as well as the tibia, and then the middle third of the whole patellar tendon. And even though it sounds, quite intrusive to take that much, we found that people have done very well, even in terms of, extending the leg out without any deficits with that graft. Now, with those grafts, the reason why they're so effective and what we would consider the gold standard or probably the best in this population is because you can get back to sports within about 5 months rather than the standard 6 months with another autograft or 9 months with an allograft or a cadaver tissue, because you have bone-to-bone integration of the bone blocks in the tunnels. And those, again, generally use screws. So that's why we don't use that one in immature athletes, but we use it in high-level or athletes basically in football, soccer, volleyball, basketball, where there's a lot of pivoting, cutting, twisting type motion. Then as you get older, it becomes less clear. It depends on how much you're doing, whether it's just recreation, weekend warrior stuff, or high-level marathons, or even active in sports at a professional level. And so kind of getting away from the autografts or your own tissue, if you're basically a weekend warrior, just do some jogging, not really doing any heavy pivoting or twisting, then we start getting into allografts, which are cadaver tendons such as anterior tibialis, Achilles, and peroneus longus. And those, because there's a 9-month wait period to go back full to sports, we don't do them in the younger athletes. But it's less morbidity to the patient because we don't have to take hamstring tendons, we don't have to take your own patellar bone or your patellar tendon. So from that standpoint, it's a little bit easier recovery.